Imagine this. A patient walks in with a fever, they're exhausted, and when the doctor listens to their heart, they hear something strange. Now, a doctor can't just guess what's wrong, right? They have to become a detective, following a very specific set of clues to solve a life or death mystery happening right there inside the chest. So you've got these symptoms, they're kind of vague, but you know they're serious. Is it this disease or is it that one? A wrong turn here could be, well, critical. That's exactly why doctors don't rely on hunches. They have a handbook, a proven method to make sure they get to the right answer. And that method, it comes in the form of something called diagnostic criteria. Just think of these as the official rule books for a medical investigation. They're basically these super detailed checklists that guide a doctor all the way from, something's not right here, to a precise confirmed diagnosis. All right, so let's open up our first case file. This is a big one, a really dangerous heart infection called infective endocarditis. To solve this case, our medical detectives use a very specific set of rules known as the Duke criteria. This is pretty much the gold standard for cracking this particular mystery. So first things first, what are we even dealing with here? Well, infective endocarditis is when bacteria manage to get into your bloodstream and then they set up camp, right on the inner lining or the valves of your heart. Yeah, the stakes are incredibly high, which is why getting the diagnosis right and getting it right fast is just so important. And the Duke criteria framework is actually brilliant in its simplicity. It breaks all the evidence down into two main categories. First, you've got your major criteria. These are the smoking guns, the direct, undeniable proof. And then you have the minor criteria. These are all the supporting clues, the circumstantial evidence that helps you build a rock-solid case. So what are these smoking guns? Well, the first one is finding the actual culprit. That means drawing blood and literally growing the specific bacteria that are known to cause this infection. The second is catching the damage in the act with an echocardiogram. That's a heart ultrasound. It can show you a mass, an abscess, or maybe a valve that suddenly started leaking. It's direct visual evidence. You can't argue with it. Now, the supporting clues are where the story really gets filled in. Does the patient have a pre-existing heart condition that makes them more vulnerable? Is there a fever? And then you have these other two, vascular and immunologic phenomena, which is really just a fancy way of saying there are specific signs, like little spots on the skin, that show the infection is causing trouble all throughout the body. Okay, so how does a doctor officially crack the case? It all comes down to a clear formula. If you find two of those smoking guns, those major clues, boom, diagnosis confirmed. Or you could find one smoking gun plus three of the supporting minor clues. And get this, even if you don't have a single major clue, if you gather 5 of the minor ones, that's still enough evidence to make the call. It's systematic, it's methodical, it's not a guess. Okay, let's switch gears and open up our next case file. This one is for rheumatic heart disease, and it requires a completely different rule book. This one's called the Jones criteria. Totally different disease, totally different detective work. See, rheumatic heart disease is a whole different kind of villain. It's not an active infection happening in the heart right now. Instead, it's the long-term damage that was caused by the body's own immune system after it fought off a strep throat infection, sometimes years earlier. It's like the autoimmune ghost of an infection from the past. And this is the absolute crucial point, so listen up. You can't even begin to use the Jones criteria rulebook unless you have proof of the original crime, that past group A strep infection. A positive throat culture or a specific blood test for antibodies is the key that unlocks this entire investigation. Without it, you're looking in the wrong case file, period. So for this disease, the major clues aren't about finding bacteria in the heart. Nope. It's all about finding signs of widespread inflammation caused by that haywire immune response. We're talking about things like an inflamed heart, super painful joints, and even some really specific things like involuntary movements or strange skin rashes. The supporting clues, the minor ones, they all follow that same theme of inflammation. So you'll see things like pain in just a single joint, a fever, of course, and lab tests that show really high levels of inflammatory markers in the blood. Even an ECG can pick up on electrical changes in the heart that are consistent with all that inflammation. The formula for this diagnosis looks kind of similar at first. You need either 2 major clues or 1 major clue plus 2 minor ones. But, and this is the critical difference, whichever path the doctor takes, it always requires that proof of a past strep infection. That is the mandatory first piece of the puzzle, no exceptions. So let's step back for a second. We've got two very different diseases that can both damage the heart and two totally distinct, highly methodical rulebooks to tell them apart. So why is this separation so critical? Let's put them side by side and it'll be crystal clear. Okay, let's break it down. For endocarditis, the cause is a direct bacterial attack. For rheumatic heart disease, it's an autoimmune reaction gone wrong. The key evidence for one is finding the actual bacteria or seeing the damage on a scan. For the other, it's all about finding signs of inflammation. And, most importantly, endocarditis has no prerequisite, but rheumatic heart disease absolutely requires that proof of a past strep infection. See? Totally different. And that really is the whole point. This isn't just some academic exercise. The source material says it perfectly. These structured criteria help to accurately diagnose and differentiate between these conditions. It's all about accuracy. You have to keep doctors from confusing two conditions that need completely different treatments. One needs heavy-duty antibiotics now. The other needs anti-inflammatories. Getting that wrong could be disastrous. So if there's one thing you take away from all this, let it be this. A structured diagnosis is a safer diagnosis. These checklists, these criteria, they replace uncertainty with precision. They take a confusing mess of symptoms and turn it into a clear path forward, and that directly impacts a patient's chance of a good outcome. It really leaves you with a final thought, doesn't it? We don't often think about the rulebooks and the checklists that doctors are using behind the scenes, but when you realize what they prevent, you just have to wonder. Every single day, across the entire world, how many lives are saved simply by trading a guess for a diagnosis?